Hello, Simca listeners, and welcome back to our podcast and our conversation today about emergency medicine and how we interact, how we communicate with our emergency medicine services EMS space. So I have two guests to talk with us today about this interaction, about how we can optimize ourselves, our environment, and a lot about communication style, hopefully, is a direction we can go so that we can receive patients the best we can provide the best care that we can. So we're joined today by Will Berry and Ross Orpit from the Loud and Clear podcast. Will and Ross, tell the listeners a little bit about yourselves and the work that you do.
Well, hey everyone, my name's Will Berry. Currently, I'm a flight paramedic in North Carolina. I've been in EMS for 16 years, started out as an EMT basic in the mountains of Colorado. Did most of my formative time as a paramedic in the city of Denver, which is where I met Ross, but I'll let him talk about that. And we've been doing the Loud and Clear podcast for over 6 years now. And our goal is to bridge the gap between that initial training you get as a paramedic and all of the hard knocks training you get on the street as a provider out there.
Yeah, Jason, thanks so much for having us. My name is Ross Orpit. As Will alluded to, I met him working for the Denver Health Paramedic Division. My path to EMS and medicine was very not straight lined. And when I finished my undergrad, I thought I was going to be a physical therapist, was bored out of my mind in the physical therapy office, and decided to go to medical school and decided to just get my EMT as some experience on my way to medical school. Got my EMT, worked on the ambulance, and fell in love with EMS, so much so that I put off going to medical school for 4 years. And all in all, in medical school and before, worked for 6 years in EMS, most recently at the Denver Health Paramedic Division. I did eventually go to medical school and finished and did my emergency medicine residency at Denver Health. And then I did an additional year of training in EMS. So I'm a board certified EMS physician as well, and currently work in Southwest Colorado, where I work in an emergency department as an emergency physician, as well as provide EMS medical direction for some agencies in my region. Like Will said, I started the podcast. Originally was called EMS Cast, my 4th year of residency with another co-resident who was in EMS before going to medical school. And we started it because when we finished paramedic school, there really wasn't a lot of continuing education for paramedics out there. If you wanted to learn more after paramedic school, really all you were left with was physician podcasts or physician textbooks, which were fascinating, but a lot of it didn't apply to you in the field. And that is why we created the podcast 6 years ago. Since then, there's been an explosion of EMS specific continuing education, which is phenomenal. And so Will and I sat down and really got clear on what do we feel like people need now. In fact, we talked to a lot of paramedics to understand exactly what they felt like they were missing now after paramedic school. And that led us to rebranding the podcast, the Loud and Clear podcast, because we wanted people to really understand what mattered to the patient in front of them. There's a lot of high level, nuanced discussions in education out there now, which is phenomenal, but we can never lose sight of the forest through the trees. And so that has kind of become our guiding principle. In fact, our subtitle for the podcast name is EMS Guiding Principles, because at the end of the day, all of this high level education is great, but we need a set of guiding principles so that we can navigate the uncertainty and connect that back to the patient in front of us. And through that, and that research has led us to create the Paramedic Confidence Builder, which again is all tailored to provide some specific coaching, mentorship, and foundations for newer paramedics to navigate this uncertainty and fill the gaps that were left behind from paramedic school.
Man, that's fantastic work. And the audience can probably see how our paths have crossed, because we're working in the space of skill decay. Maybe that's a little further out. You're certainly providing an unbelievable service to new paramedics and medics kind of looking and entering after, the training and the safety net is in the rearview mirror. So I'm glad we've gotten, kind of the kindred spirits together. Thank you for what you're doing in the EMS space. And so happy to have such experience and knowledge base on our podcast. So looking forward to talking about the interaction. As I mentioned, I think the optimization really of how EMS and EM interact and work. So if it's all right with you, I'd like to kind of dive into this. I think of it in 3 categories or sections: preparedness, communication, and expectations. How's that sound to you guys?
Yeah, that sounds great.
Let's dive in.
All right, let's do it. So first one I want to get into is preparedness. So we talk a lot about this, as I mentioned in the SimKit podcast, about us as emergency medicine practitioners and how we prepare ourselves and really, in a lot of ways, maintain ourselves for the emergent patient, right? There's too many procedures out there that we need to be fresh on and smooth with. Skill maintenance, mental preparation, team preparedness on a day-to-day level. What's going to come through your doors is really important to me, and obviously something that we share in that space. So one interesting thing, kind of like in the black box area for me, is we receive so many of these critically ill patients, the patients that we need to intervene on rapidly, halo procedures, all that space, from our pre-hospital colleagues. But I have no understanding of their world, of what they experience in that same area of skill maintenance, skill decay, those things. So what is the process or structure out there? What recertifications might they be undergoing? How at risk for skill set decay are our paramedic colleagues? So long-winded way of asking you guys, tell us about this space. And Ross, in particular, as you walk the line between emergency medicine and EMS, talk to us about the contrasting or similar landscape for the EMS provider and the EM provider, if you can.
Yeah, it's interesting when we did a little mini research project when preparing to create the paramedic confidence builder, and what we found is almost every paramedic, no matter their situation, whether they work in a big, busy urban department or a rural department, experiences very similar challenges with regards to getting better, preventing skill decay, and being prepared. And everybody faces it for different reasons. So if you work in a big, urban, busy department, your system is just so busy that despite having a lot of resources, you're just trying to keep up with calls. So you don't always have the time to sit down and train and dedicate some resources to helping train your providers. Whereas if you work in a rural setting, you have the time, you just don't have the resources or the manpower or the knowledge base to provide some of that training for your providers. So it's a real challenge, but it is the job of EMS is to be prepared for these disasters, to train for the unexpected, for the calls that you're not always going to see. And the challenge becomes much more difficult compared to us in the emergency department, where we may see, 20, 30 patients every shift. They're going to see less than 10 every shift, and they're going to work, maybe 2 to 4 shifts a week. And so the exposure becomes a lot less, and the opportunities for some of these things become a lot less, but the time sensitive nature of them doesn't change at all. And so the need to be prepared still exists. And unfortunately, a lot of it has fallen on the onus of the individual paramedic to decide how to maintain those skills. And that's kind of what we created, why we created what we did, because that can be challenged if you don't know what next step to take,
Mm-hmm.
Yeah, I would chime in. My perspective coming into this. So all of my experience prior to EMS was in the outdoor world. And that's actually what got me involved in my initial emergency medicine exposure, was guiding. And so something that I've reflected on quite a bit is in the outdoor recreation world, rock climbing, whitewater rafting specifically, there's a lot of skills you need to have, and your safety and the safety of other people depend upon them. And there's this, there's kind of this shared tribal nature around it of like, hey, if you're not comfortable with that knot, like, let's practice it again. Like, because if you don't know it, well, you're going to hurt me, you're going to hurt you. Like, let's just keep doing this till it's solid,
Mm-hmm.
And then going into paramedic school, where that was an exposure for me of like, well, you only need to have 5 intubations on the books to get your certification. And so, and 1 or 2 of them can be on a mannequin if you don't get the opportunity to intubate a real person. And for me, I was like, that just doesn't feel like enough. I know within me, I'm not comfortable with that because I'm self-aware enough of my skills to know, like, I'm not good at it.
Mhm.
And I think I brought that mentality for myself in of like, if I am on a river and I tell the person next to me, like, no, I'm good, I got this, they're going to tell within about 10 minutes, Will don't got this. That self-awareness, but within that, it's a very loaded topic, right? Because people start to feel like an imposter, like, oh man, I learned this, I should know it. Is my friend going to figure me out? Is my agency going to figure me out? I work with all these people that I respect and I know, and they all seem to have it all together and I don't. Like, how am I going to pass this insurmountable, hurdle? And so, that's something that Ross and I are really trying to overcome through the mechanism of community of, hey, let's come together. Like, if you're not comfortable with this, what can we do to help you get there? Because you've taken this huge step in self-awareness to say, hey, I actually don't feel like I know this very well. Well, cool. There should be people around you to say, like, let's get you there.
Yeah, fair.
And some agencies do that better than others. Some agencies do have like procedure minimums for the year. And if you don't get, like, say, your 10 intubations for the year, then you spend a day in the OR trying to get those intubations. And that is phenomenal. But I know that there are a lot of agencies that want to do that. But unfortunately, the ORs around them are also having to deal with, accommodate other learners. They're having to accommodate, nurse anesthetists who are in school, or paramedic students, or, and so it becomes challenging for them. And, some ORs just aren't willing to take learners or students. So it can be challenging even if you want to do something like that. But some people have like I've tried to implement in most of my agencies, like an annual procedure checklist to make sure that quarterly you have gone through these procedures with a trainer and somebody who has walked you through. And I have, I've created a, like, for the trainer, like, these are the things you're looking for, these are the things you're teaching on. And then for the trainee to go through those. But if you don't have that, then it's on your own. And I strongly encourage people to create their own checklists. Like, every quarter, I want to make sure I hit these competencies. And here's my document for the things that, like, I'm going to practice it and then look at the document and be like, what did I forget?
I like that. I like that you're in the space of kind of training the trainer. And I recognize, Will, as well, we talk sometimes about known unknowns and unknown unknowns, right? And the most dangerous, I think, is the unknown unknown, who thinks that they are ready to, hit their shift and take care of whatever comes through the door, comes over the radio for you guys, and doesn't even recognize that they've lost their skill, that they've moved from competence to incompetence. But then we get in this space and it seems like we're kindred spirits again of known unknowns. Okay, I know that I'm getting shaky on an IO insertion or an intubation or, a lateral canthotomy for us. I can continue to fake it till I make it. I can keep that imposter syndrome going and just hope that it's rare enough a thing that I don't have to get called out by a colleague or have a patient with a bad outcome that puts me in an M&M. Or I can lean into my community. I can lean into my colleagues and developing and refining and keeping these skills up. And it sounds like, from a structural standpoint, it's very site specific in EMS, just like it is in emergency medicine.
It is. And I think, to more directly answer your original question, I think paramedic training, we just don't get the same number of repetitions with some of these things. And it's just the unfortunate reality. And that's not knocking the accrediting bodies or the certifying bodies, but, like, we just don't. And our opportunity, intratracheal intubation is just the easiest skill to point towards, because it becomes kind of it's a critical skill, it's time sensitive, and it's kind of a hot button topic in EMS. But our initial training requirement is relatively low. It is low. The other thing is, there's many tentacles that spread out. The amount of the research we point to frequently has to do with in clinical environment instead of the pre-hospital environment. And then, we don't know our sometimes we're being taught by other paramedics that are in a similar boat. And so, there's some of this institutional knowledge is lacking, like some of that tribal knowledge isn't always there. And so back to kind of what Ross said, some of the agencies do a really good job of owning this, taking it on and trying to fill these gaps. And then some of them just can't for either time, money, both. Mm-hmm. And then you get into this other piece too of so many of the emergencies we lean into as paramedics on the street and physicians in the department is like, we're not using any of these skills. This is like, asymmetric problem solving. Like, what are we trying to figure out here?
Fair. Yeah, I think I appreciate that analogy. And it sounds like there's whispers almost of probably a higher degree of awareness and facing of a challenge. And it's always an uphill battle, right? Time doesn't heal all in our space. It, leads to skill decay and incompetence. But because of the breadth and the austerity of the anticipation of austerity in that EMS space, maybe there is a little more recognition that just what you're doing on runs is probably not adequate. Let's see what we're doing in terms of our reps, the trainers, and the checklists, like Ross mentioned, is hopefully or maybe more robust than what I've heard from medical directors in departments who, we have our, annual CLABC training and we have to do our central line, but outside of that, it's just what comes through the door. So it's an interesting shared experience for us for sure.
Yeah. I think in an ideal world, part of the job would be understood that, you're not just running calls, and this is probably different there are busy departments, right? They're busy urban departments who are working not 24-hour shifts, but they're working 10-hour shifts, and they're seeing 10, 12, 15 patients in that 10-hour shift. And that, like, what training looks like for them is going to need to be fundamentally different than the department that works like a 24-hour shift and sees maybe 6, 7 calls in those 24 hours. But I think in an ideal world for that department that is like more structured, like 24 hours, seeing 6 or 7 calls, having an understanding that like part of the job is not just like running those calls and waiting for those calls to get it to come in, but part of the job is actually training. So you show up and you train, and sometimes that training gets interrupted by a call, and then you come back and you go back to training. And that, like, having an understanding of like, that is actually what your job is to be prepared.
That's awesome. That like gets me jazzed up because that's how we should all be thinking in that space. And so, yeah, thank you for kind of, letting us look behind the curtain a little bit in what it might be like there. And certainly gives, if you're a listener here, an opportunity to understand your local EMS operations. If you're interested in education or even your own skill maintenance at all, I'm going to put a plug for reaching out and seeing if you can get involved in these type of training opportunities on a monthly, quarterly, whatever, even annual basis would be great for rapport, great for communication, team efficiency, and then your own skill upkeep. All right, I'm going to transition us a little bit. I want to, we're talking about our 3 areas, and I want to get a better sense of that communication. That was that second area I wanted to pick your guys' brains. And so as an EM physician, I believe it was my intern year. I think it was like my second month. I did my EMS month rotation, and I was in the back of an ambulance, and I was nervous and a fly on the wall. And then that was it. That was my EMS training in its own regard, in terms of an experiential side. During residency and after, I've been involved in radio calls ad nauseum. We've all had more of those than we could count in terms of either listening in, asking our handful of questions. Some piques our interest, and we come over to the radio and see what's actually going on there. But I never really, through that experience, got a true sense of the training or structures that may be implemented by paramedics for arrival to the department. So, Ross and Will, I was wondering what education is out there for the EMTs and the paramedics. How adequate do you think it is? And what supplements are you guys doing in the space of, reporting? I love the title of your podcast, Loud and Clear for the Room. But like, how do we, what structures are out there? What's part of paramedic training? And then what is needed to maintain it thereafter?
Yeah, first and foremost, regarding paramedic training, it's very individualized. So, you know, just honing in specifically on the communication between the field provider and the hospital, for example, that happens different ways depending on where you work. Some places you communicate with a phone, some with a radio, and the expectations are different. Sometimes you're expected to only call if the patient's critical, otherwise you just show up. Sometimes you're calling in a trauma activation based off that receiving facility's criteria. And so when you're going through your initial paramedic training, you honestly don't get a lot of training in this topic because they'll punt it to your field internship experience because it's so unique to where you're going to be. And then it's on top of that, it's going to be unique to who's training you, right? And so are you getting good instruction or not? Like some of it's phenomenal because that's a critical link between the field provider and the hospital. And some of it's more like, well, if you say this, then you're going to get a big rise out of them. And that's really what you're after. And it's like, well, that's not good. Right. And then I think Ross and I are somewhat biased because we both worked at a phenomenal place that really, Denver Health really cherishes the connection between the field provider and the emergency department physician. We would call on the phone, and when we called on the phone from the field, we were going to speak to a physician every single time. We never talked to the charge nurse, for example. And so there was a lot of pressure put on us during our training process of like, hey, their time is important. They're dropping everything they're doing to give you their undivided attention. So you need to speak professionally, speak concisely, follow a format, and have this professional exchange with them. And so I think, and then that professionalism was reciprocated. So I think we really were raised in a place that spoiled us in some ways, because it's not like that everywhere. Some systems, you make base contact for your ACLS algorithm, which is just, seems like a waste of time to me. But yeah, it's very dependent on where you are with that initial aspect of your training.
And yet communication is such a pivotal piece of the patient's journey and care journey. I mean, what's the study that looked at 80% of medical errors can be tied back to a miscommunication. And I don't know that around the country, like Will said, we were lucky to train in a place, and we're biased obviously by that, that took this very seriously. And, in the Denver metro area, there was a physician at every handoff report. So when you showed up to transition care to the patient, there was a nurse, physician, and usually a tech as well. So the entire care team was there. And that is important. It's important to better outcomes for the patient. It's important to more efficient care for the patient. It's important to you as a physician. This is one of the things that I really want to get across, is how important this is to you as a physician. It is not just an interruption in another interruption in your very busy day, but the paramedics have access to information that you will never have another opportunity to get access to. They know what the vehicle looked like. They know what bystanders said on scene who aren't coming to the hospital. They know what the house looked like. They maybe even looked in the fridge to see if there was any food in the fridge. There is a lot of nuanced information that will help expedite your care and speed the care of the patient in front of you. It will also help you provide better care for that patient and help prevent you from making a mistake or missing something. There's actually a joint position statement, and I don't know the exact names of all the bodies on it, but it included bodies from the nursing associations, the EMTs, paramedics, emergency physicians, and national EMS physicians wrote a joint statement saying that this is so important that the entire healthcare team should be present for the handoff. Physician, nurse, tech, the team who is caring for that patient should be there during EMS handoff for that very reason. So I think it's really important. I think that across the country, I have heard, unfortunately, that is not the case, that a physician does not often show up for every handoff. And I think that's a big miss and a big detriment to the patient. When it comes to communication, it's also very different depending on what phase you're in, right? So the communication and how you structure that communication and what needs to be communicated is different if you're doing the patient handoff versus if you're doing a pre-hospital notification to let them know that you're coming in versus if you're calling for online medical direction. And so if we take, say, for example, the patient handoff, right? We want to give a good, concise, comprehensive picture of, what we saw when we were there, what we were told, what we did, and how things have changed since we've done those things over our time with the patient. When you talk about the pre-hospital notification, we really just need to give the bare minimum information that is needed by the hospital in order to help set them up to be prepared for your arrival. And sometimes that's like, this is a very routine, non-critically ill patient. We just need a room sort of thing. And there's not a whole lot of information that needs to be communicated other than communicating that. Other times it's like, this is a sick patient and these are the things we need you to be ready for when we arrive. And then when we're talking about online medical control, all of that is about creating a shared mental model. The physician cannot see what you see on scene right now. So you need to find a way to create a mental model in their mind over the phone to help them understand exactly what's going on and the guidance you're asking for or the order that you're asking for. So the online medical control is all about the mental model.
That makes a lot of sense. And it's helpful to sort of think about the goal and objective of each of those different types of communication. And in my simplistic mind, I just thought of them all as communication, but there's a lot of different motivators. And to paraphrase, and you correct me if I'm wrong in that space, there's not a specific universal structure. It's not like, Dubin's EKG interpretation or every paramedic rate, rhythm, axis, interval, hypertrophy, ischemia. It's not that in terms of how reports are given in any of these areas. To Will's point, a lot of that is going to be location or geographically specific, which makes a lot of sense to me. Doesn't make sense to learn complex and intricate presentation styles when you go out and practice. Everyone's like, stop talking so much. We need just the base. You're going to need to be site specific, region specific, and case specific. But so to confirm, there's not necessarily a structure that is outlined or that you have found across your paramedics with whom you worked.
Yeah, this is a really good point to clarify, because just like in medicine and diseases, there's not a clear structure for every single one of your patients that you see. And this goes back to what we're doing in the podcast, and what we focused our attention on is instead, it's a set of guiding principles for each phase of it. So the principles are kind of what I just discussed.
Yeah.
Some structure is needed, and we do teach some of the structure, and we can get into some more of the detail of what the overall structure looks like. But especially when it comes to the handoff, there's been some push for some very structural handoffs. So I missed or S-bar, or some people are very regimented to you have to follow this structure. And I push back against that a lot, because I think the risk of doing a very structured handoff is that sometimes you forget to give information because you're like, I can't say that here. I need to wait until the section. And then when you get to the section, you're flustered by everything else you say. You forgot to say that thing. So it lends itself to potentially leading you to actually forget information. It does help with remembering information too. So there's a balance between the two. Mm-hmm. The other thing it can do is it can cause you to bury the lead. So there may be a critical crux to this entire care, but it fits on step 4 of this handoff. Mm-hmm. So you don't say it up front. And so as the physician or nurse is listening to your handoff, they have a different mental model up until the point that you get to that crux, and then everything in their mind suddenly has to shift. Yeah. And so it also puts you at risk for burying the lead. So I think structure is good, but having some flexibility within that structure is really important as well.
That makes sense. And thank you that's helpful to have a general sense. And we can put some of those, we all know S-bar, but some of those other structures that people might reference or utilize in the show notes. Again, encouraging a lot of cross communication after the podcast for our listeners for what their EMS crews prefer, what they're taught, compare and contrast, so that we're all on the same page there. Within this space, and Ross, I appreciated your direction there, and even thinking about burying leads, you can get all the way through, and patient's DNI. Okay, that really that was the thing, that we missed in the beginning because it wasn't allowed until our very regimented structure allowed for it. But I want to kind of get a sense about, and this is a very probably overly personal area to wonder about, is the balance of confidence and intrinsic doubt that comes with all of the medicine we do, but particularly for our EMS colleagues, which I think sometimes, to use modern terms, might be getting shade thrown at them from the EM crowd. We in emergency medicine, we live and breathe it, but we still do to others. Just everyone who's provided care before you, there's always that internal judgment, that Monday morning quarterbacking. And as I said, the cardiologist is going to be, well, if you're not really worried about ACS, why are you ordering tropes? Like, I can't not order troponins in this, 65-year-old with some chest funniness, even if he's not describing it as pain. So we know that happens in medicine, and we do it to our own friends and colleagues in the EMS space. We question, we critique, we Monday morning quarterback. And I suppose my question might be best asked in almost an example about being able to show confidence in the report, but doubt intrinsic to a patient case. And so, verbiage that might highlight that, which could further affect our degree of understanding or confidence in the EMS colleague is, arrived on to the patient and they were in VTAC, is different than, we got to the patient and they appeared to be in VTAC. Or the one that's super common for me sometimes is the initial pulse ox was 65 versus, we didn't have waveform or the fingers were cold, initial pulse ox read as 65. And you see just subtle differences in portraying things that way. And do you guys, work in that space with your customers, with the people with whom you educate about maintaining confidence, but the ability to show some of that doubt that's intrinsic in handoffs and the receipt of patients in busy field environments?
Yeah, that's tough. I think underpinning all of this is if we all lean in with some healthy level of skepticism at all layers of the care, ultimately the patient should be getting better care, right? Because maybe the next rung on the ladder sees something that I missed. Mm-hmm. Now, within that, what I would hope as a paramedic is to be treated with some level of respect, like, hey, let me tell you what I was up against on this call. And this is slightly a sidebar, so I forgive me, but this call came to mind as you were talking. Mm-hmm. I was on scene of a standby for the SWAT team, and they had a barricaded subject. So they had a bad guy in a house with an alleged hostage. Ultimately, they got the bad guy out. They then swept the house, and they found a woman in the attic hiding from him. So they get the woman out of the attic, and she is not well. Mainly, they want her evaluated by paramedics. Okay. So I take care of her, and she physically fought with me nearly the whole ride to the hospital, telling me things like, "You don't understand. They're watching. They know that if once you go into the ambulance, you're gonna like rat them out. Like, I don't want to be doing this." But she needed to go for evaluation. She had sustained, ungodly trauma at the hands of this person they had just arrested. And when we arrived at the emergency, she kept saying, "I'm going to leave, I'm going to leave, I'm going to leave." And a lot of she could string together enough coherent thoughts to probably pass like a really quick capacity assessment. So the hospital staff was doing their shift change. And normally, like Ross said, a physician would come to the bedside for the handoff, and no one did. And I knew, like, if they don't hear my story and they just hear from her, like, I don't know why the paramedics brought me here, I want to leave, they're going to let her go. And she deserves a workup. Yeah. And so I sought out the docs, and thankfully one of them I knew, and I just said, "Hey, I'm really sorry. I know you guys are busy trying to do your pass off, but I really need to tell you about room 20 or whatever." Mm-hmm. And they were very appreciative of that. And so I think where it relates back to what you're talking about is being respectful and professional, right? We all want to be treated that way at all rungs of the care.
Mhm.
The other thing too is, as a paramedic, I need to recognize the limitations of my knowledge and skill set, but also be confident in the pieces that I have to give you, that you have, like Ross said, you have no other way to get this information. This woman in my story, she's not going to offer up to the doctor, I was just held hostage in an attic for potentially days and like sexually assaulted. She's not going to tell anybody that. And so like my point is, all of us have to check our ego a little bit, right? Which is really difficult to do. But I need to arrive at your emergency department knowing I don't know everything, but the things I do know, I need to make sure I'm confident in those things. I'm confident how I obtained that information, and then I can communicate that professionally to you.
I like that. I like that further highlighting of confidence of your experience, right? And in that same space of balancing doubt and confidence, the things we're certain of, and have that obligation to the patient and the transition of care, doubling down and maintaining oneself and having the chutzpah to kind of do what you need to do as your example led along is valuable. So I appreciate that.
Yeah, I think we often confuse confidence with arrogance, or we fear confidence coming across as arrogance, and they are not the same thing. And one of the things I try to get across to paramedics that I teach is that one of the wisest things you can do is say, I don't know. That doubt is okay, that we live in doubt and uncertainty. This job is doubt and uncertainty. And we just have to learn to navigate that and be okay with that, and somehow still provide confident care through that. There's when I was a paramedic, I often heard, as a paramedic, you are not always right, but never in doubt. And that can be taken well, or that can be taken poorly. And that comes back to the confidence or arrogance piece of it is like, you need to have the confidence in what you do know and what your principles are. So for example, the basics are always true. The ABCs are always true. You can always be confident in falling back on that, even if you don't know what's going on. And a lot of the rest of the case is in doubt. And it is okay to express that doubt. It's okay to express that uncertainty. It's okay for that to live, because that is emergency medicine, especially in those first 10, 15 minutes. And so when you're being asked about those things, or when you're being expressed about those things, you need to actually have the confidence to not know, to be in doubt, to have some uncertainty, and be able to communicate that. And then you need to have the confidence to be questioned, to be asked about things, to have clarifications come your way, to be able to provide those with like, here's the things I'm confident about, here's the things I'm not so confident about, and that's okay. Communication is a two-way street though, right, as well. So us as emergency physicians, one of the most important things we can do is not interrupt. One of the most important things we can do is, as they're giving that handoff, as they're giving the report, is to stand there quietly and listen. Don't try to multitask. Don't try to do a physical exam while you're doing it. We cannot multitask. All we can do is task switch, which means we're switching off of listening to the information they're giving us. And so stand there, take in the information, and hold your questions until the end. And then when you do have questions, ask them respectfully and professionally. And so, you may say something like, okay, so when you arrived, you mentioned the pulse ox was 65%. Did you happen to see the waveform with that? Like, was a really good waveform? Are you really confident that it was 65%? And all you're doing is clarifying, like, I'm just trying to get a clear picture. Like, yes, we are confident it was 65%, or maybe was there some ambiguity there? Because right now it looks different, but maybe it's different because of the things you did. And so I'm just trying to here. And then the other thing I always say is, like, best practice is usually to praise in public and reprimand in private. And so if you do have some constructive feedback, unless you have a great relationship with that, where you can like some of my paramedics have pushed back against this, because they're like, no, people need to see that this is okay. Like, people need to see that, like, constructive feedback is okay, and it's good for me to get it and learn and receive it. But others not so much, right? And so, like, unless you have a really good relationship with them, sometimes it's best to like pull them aside, go out to the ambulance bay, and then have a private discussion about, like, hey, here's what I noticed. Here's maybe what I think could be better. And And honestly, as a paramedic, you should eat that up. And as a physician, you should make efforts to do that, because everybody wants to get better and everybody wants to understand how the other works and what the other is looking for and how we can work best as a team. And so I think that's best practice. And if we're all confident enough in ourselves, we'll be able to have those conversations openly.
Yeah, I want to add another thing too. So much of what a paramedic wants is they want to feel like you see how much of a challenge they just went through.
Mm-hmm.
And so our skill set is narrower and it's very defined, right? At those initial moments of a critical patient. And so within our small piece of medicine, we're making some of the same critical decisions that you guys are in the emergency department, but within our small window, right? And all we want to hear sometimes when we get to the hospital is, good job, I would have done the exact same thing. Or I'm seeing this a different way. Let me tell you what I'm seeing, and have a professional back and forth so that when I see it next time, remember, a lot of times paramedics are out there alone. Yes, they have a partner, but in some services, a paramedic is paired with an EMT basic, which means they're the only person on that scene with their level of training. And so they're trying really hard to do the right thing with their limited tools, experience, and training. And so to have the physician in the emergency department say, hey, good job, or hey, I see this slightly different. Let me point out to you what's informing my decision about my care. You're like, oh man, awesome. I can take that with me on my next interaction.
Yeah, if you truly understand and convey, that in the pre-hospital setting, outside of your 4 sterile walls, like things are chaotic and incomplete and constantly moving and abbreviated, like Will mentioned. It can help if you have some grace for the somewhat lack of information that you wish you may have had. If you're able to express that to the provider, they will likely give you more leeway with the clarifying questions you have for them.
There's so much awesomeness in what you guys just said. I'm going to try to do a quick summary. I think one, awareness. It's easy, as I said, for a cardiologist to question our orders. It's easy for us to ask, like, why didn't you do this? When we have absolutely no understanding of the scene, the person, in the rig with them, the fact that they might be operating alone, all of those elements that we just assume they have a similar structure, similar support system that we have. I really like the, I'm gonna botch it, I think, Ross, but the praise in public and critique in private, that general sentiment. And even I know I'm at fault in this regard. Just the simple, like, awesome job, man. That was a fantastic report before carrying on with the patient probably builds relationships more than a lot of the other things that we think that we're doing. And so those simple little elements there. And as you guys were talking in this space, I think it comes down to just simply humanism, being overly philosophical and waxing here. But, I'm a spouse, I'm a father, I'm a son, and just the way we communicate with one another in these ways is no different than how we talk to our significant other, for an example. The I's versus the you statements, and like the how confident were you in that waveform, or, those types of questions versus were you confident in, or how confident, the way you phrase those parts are really important, and just being sort of thoughtful and trying to avoid anything that could be seen as a insult or a critique on the quality of care that the person is giving, I think is important. So, what's your degree of confidence in? I was actually stumbling over this as I was thinking about it. What's your degree of confidence in that waveform is probably better than even how confident are you in that waveform. So just thinking simply about how we ask those questions and the insinuations that could come with them, I think can go a long way.
Yeah, absolutely.
All right, I'm going to carry us forward. I feel like I could continue in that space, but I appreciate all of that information in the communications space, and also getting into what is, notably a touchy subject, but one that I think if we don't think about it, becomes more touchy in real time when we're trying to get some information about the natural doubt that's intrinsic to medicine versus doubting the provision of care beforehand. But now I want to ask a little bit about expectations. And, as the receiving institution, as a receiving clinician, what is allowable, I guess, right? So request expectations for our EMS personnel via the radio or, anything really prior to arrival. We talked about it being on the telephone in different capacities. And so it is two-sided, I think. There's the element of what can we, as the command phone holder or the EMS person receiving the patient, what can we ask of our paramedic colleagues prior to arrival? And then sometimes, particularly I feel like in the critically ill or pediatrics, I want that patient brought very rapidly to my ER, and the asking of stopping or not doing things that are within the scope of practice of the paramedic, that is also a bit of a touchy subject, right? So to explain this again more by examples, right? So in a person that we want to rapidly transport, asking or saying, please don't progress to intubation in the field. If you're comfortable doing so, place an LMA and transport expeditiously. I think that sounds good to me, but I don't know from your guys' perspective. So what recommendations can you give us EM providers about those two sides? Let's start with what is a reasonable request in the stabilization or work done by our EMS personnel, and then we'll hit the please don't do that side after. Sound okay?
Yeah. I think, some of this comes down to having an understanding about, what they can and cannot do, and the limitations of the scene, the limitations of their ambulance, the limitations of their equipment. And so this is a shameless plug to learn more about your EMS systems and what equipment they have, what medications they have, what is within their scope of practice for their level of certification. And one of the best ways to do that is just, if you don't know, like if you ever have that thought of like, I wonder if they have this medication, I wonder if they can do, just ask. Sometimes as physicians, we're a little embarrassed to ask too, because we feel like we're the ones who should know, right? But the more you ask, the more you'll learn and the better you can work together and as a team. So I think that's the first principle. The second thing I would say is this again gets split up by where we are in the phase of communication. So if we're talking about when it comes to the receiving the pre-arrival notification, remember that in that moment, you do not need all of the information. The time will come when the patient's in the emergency department where you can ask more questions and the questions you need answered. Right now is purely what will change your response and preparation prior to their arrival? What information do you need to know to make sure that you are ready for what is about to walk through the door? It needs to be brief. You need to keep it brief because they have more work to do on the way to the hospital. They're coming with a sick patient and they have probably about 10 things they want to get done before they get there, one of which is to let you know to be prepared. And so if the patient is sick and they have more work to do to continue to care for the patient before they arrive, try to keep it brief and just get the information you know. And I have actually a biophone call that I'd like to play that kind of highlights this principle pretty clearly, if I can.
Absolutely.
DG Base, Dr. Sancroft, go ahead.
Hey, yeah, Garcia on 34. Can you hear me okay?
Yeah.
Hey, we're Coach ND with a 30s male, self-inflicted stab wounds. Had some pretty deep lacerations to the bilateral arms, and probably about like a foot-long laceration kind of from the left shoulder to the left abdomen. Looks like adipose tissue, but no lungs affected. Blood pressure right now 60 over palp, and we're probably about 5 out.
60 over palp?
Yep.
What's his pulse?
120.
How much blood was there on the scene?
Oh, man, I'll talk to you when I get there. Probably about 2 liters.
Okay.
So this is a perfect example of like what information do you need to be prepared for that patient? You need to know what the mechanism of the injury was. He was stabbed. You need to know where the stab wounds were because you need to know what you need to be prepared for. So you know that he has extremity stab wounds, so you may need a tourniquet. He has stab wounds to the chest and abdomen, so you may need to be prepared to place a chest tube. And you know that he's hypotensive, so you're going to need blood ready. Like, do you need other information than that to be prepared for this patient? You may want what the pulse rate was. You may want how much blood there was on scene. But if we're honest with ourselves, that is all the information we need to be ready for that patient. So keep that in mind. Understand that he's flustered in the back of the ambulance trying to get 2 lines for you, and do everything that he needs to do before he arrives in the hospital.
And to tag on to that, I think when you hear that initial ending where you're like, oh man, I'll tell you when I get there, I'm sure most physicians are like, how rude. That paramedic might literally have his phone under his ear like this while both hands are trying to control a hemorrhage. And so I've been in very similar situations, and you're not an octopus. You just don't have 8 arms.
Yeah, no, I appreciate those elements, and again, leading with the not bearing the lead, that blood pressure early on, obviously would be nice to have early in that report. And then the practitioner, the EM provider receiving like areas involved, know the blood pressure, know the degree of extremis the patient's in, let me go get ready and let you do what you need to do.
Yeah, exactly. And so then when we shift to kind of more what maybe your question was tailored towards is that online medical control, like I'm calling for this order or for guidance. I think I really like what Will talks about when we teach our paramedics with regards to this, when they may be frustrated about not getting the answer they want, or sometimes the physician is like, you know what, just don't do anything, bring them to me, and I'll figure out when they get here. So I'll turn it over to you, Will, to talk about that a little.
The first thing you need to do when I as a paramedic get a response from the physician on the phone that I'm unhappy with, the first thing I need to do is think about I need to reflect. What did I just do to not paint the best picture of the care I'm providing? The other thing that I need to reflect upon is if I'm getting an answer of like, oh man, just bring them here, then I obviously didn't paint the picture to you of what I'm seeing and accessing. And then I also am not asking you for anything specific. If I just sound chaotic and flustered and like I don't have my care together, and then I'm putting you as the physician on the other end in a spot of like, now tell me what to do. Of course you're going to say, gee, I don't know. Why don't you just bring them here so I can see them with my own eyes? Because I can't tell you what to do. And so the big thing that we try to teach people is when you call and ask for something, know what you're asking for. Now, also be open to suggestions and ideas and, oh, I didn't think about it that way or whatever, but lead off with, hey doc, I'm calling for an order for an amiodarone drip. And then go into the story to paint the picture well, all of that. And then at the end, hey doc, what do you think about that order for 150 milligrams of amio over 10 minutes?
Yeah, so this goes back to that principle that the point of this phone call, of this communication, is creating that shared mental model so that we can be on the same page of what is going on with the patient, despite being in 2 different locations, and come up with a consensus of what is the next step forward for that patient. So being clear with your ask, like Will said, one of the most important things you can do from the paramedic side is state up front why you're calling. Because as a busy emergency department physician, we are constantly interrupted. We're interrupted, like every 17 seconds, I think the study showed. And so we're constantly trying to task switch between a whole bunch of different things. And so when you call us with something, you need to make sure that we are in the right mental space to hear what we need to hear to help you out. So whether that's, hey, I'm calling for this med order. Great. I know the medication. I know what indications that medication is used for. So now I know what I need to hear to be confident to give you that order. Or I'm calling for a refusal. Okay, I know what I need to hear to know that they have capacity and that it's not a super high risk refusal, and I can give you the okay for that. Or sometimes you need to just be like, hey, I got a weird one and I don't know. I need your help. And that tells me, okay, I need to really stop anything I'm doing right now, sit down and listen closely, because this is going to be odd and I'm going to need my full mental capacity to help you navigate this situation. And so teaching your paramedics to do that for you so that you can be in the right mental space to answer the questions they need and develop that shared mental model. I have another example here that highlights trying to get to that shared mental model with the paramedic on the other end of the call so that we can get to the right answer for the patient.
Hey, this is paramedic McFarland, DG 837. You hear me okay?
Yep, go ahead.
Calling for a field pronouncement with what appears to be a DNR in place. But it's not like a state DNR.
Sure.
It appears to be a living will.
Sure.
It says under terminal condition, it says I direct that life-sustaining procedures shall be with coroner pursuant to the terms of this declaration, it being understood that life-sustaining procedures shall not include any medical procedure or intervention considered necessary by the attending physician to provide comfort or alleviate pain. So we got signed by her, signed at the end by a physician and her and 2 witnesses and a notary. You have that?
Yeah, no, just so give me some story. But I mean,
Probably.
but yeah.
She's in cardiac arrest,
How old?
81.
81. Okay. And is there like a terminal illness or like, do we know a medical history or?
No, she got a history of hypertension, was found down by her husband. Her husband tried
Okay.
to start CPR, but
In
had
the
this
home.
living will in place.
Okay. And is the husband okay with that? Like, how does the husband feel about that? Because, I mean, granted, I appreciate that, like, she's got all this documentation, but like you said, this is not like the date most form, So, like, how does the husband, what's the husband doing?
I'll talk to him.
So we can stop it there, Will, but that is an example of like there is a complete disconnect. That physician who cannot see what you can see, who does not understand everything that has led up to that point, needs to somehow find a way to navigate developing that shared mental model with you. And so you're on the paramedic side of the call, like your job is to try to create that shared mental model. If you're a physician, your job is to try to get that shared mental model and to do it professionally and find a way to tease that out so you end up on the same page. I'll pause for thoughts there.
Yeah, no, I appreciate these sort of thoughts and consideration, and particularly those examples. And you can see in that second one where the physician is going, but I think, again, lacking awareness of on-scene provision of care. I don't know if they're actively coding this person until they're given permission to stop. There's a lack of awareness. Like, it sounds like this is in the setting of a potential terminal illness. We're fair to proceed forward so long as this is a shared opinion by those involved that can verbalize themselves. So can we confirm with the husband that this document should be adhered to right now? That little bit of information to explain that mental model would go really far for this guy's like, okay, now I got to go talk to the husband. I'll be back. Like, that's not a great communication at the end of that audio clip you played for us.
Yeah, and as the paramedic, I think about too, like there may be some, if this is bubbling up to calling, there may be some bizarre social setting that it's on that paramedic to tell you about. And for example, people threatening you, like, start CPR, I'm gonna shoot you or something like that. Okay, like I need to make sure you understand all of the situations that I'm up against so that we can make the shared decision in the best interest of the patient and in best interest of safety for everybody.
Yeah, so this sets us up with, before we can give any recommendation, whether we give approval for the order or we request that they do something different than what they originally wanted to do, before we can do any of that, we need to have this shared mental model. So that's why that is the guiding principle of this phase of communications. Now, if we get back to your question about, like, how do you handle saying, actually, I want you to do something different? In principle, we need to somehow convey our mental model of why we want to do something different with the paramedic. And so once we have a shared mental model of what's going on, we may have a different opinion because of whatever knowledge we have, maybe whatever education we have that is telling us maybe we should do something different. We need to find a way to concisely and professionally then relay that to the EMS clinician on the other end of the phone call. Like, I hear this is my understanding of the case. This is my understanding of what you want to do. I think it would actually be best to do this other thing. And here's why. Here's where my mental model is at. So I have another call that kind of highlights this. So in this call, the paramedic actually did a phenomenal job of creating a mental model of exactly what was going on at the time, but wanted to do one thing. And I actually recommended he do something else and tried to explain my mental model as to why.
Orpit. Hey there, paramedic Lee on DG16. Can you hear me okay? Had a rhythm check in 30 seconds, Peter.
I'm clear.
I'm calling for a pronouncement. I'm out with a 52-year-old male. Sudden cardiac arrest in front of stop. It was witnessed with not so great bystander CPR. When we arrived, he was in a systole. We've been working him since 13/21. He's received 3 milligrams of epinephrine and 2 milligrams of Narcan. He was a systole up until about 3 minutes ago. We have an organized PEA at 100, solid 7.02 with an end tidal of 50 at this time. Still pulseless with that PEA rhythm at 100. Unknown etiology. He does have an inhaler on him, but other than that, we don't have any history. He's got a hematoma to the forehead from when he fell per bystanders. Do you have any questions for me?
So you have a 52-year-old gentleman who was a witness cardiac arrest, received bystander CPR, was initially asystolic, but now has an organized rhythm at a rate of 100 and has an end-tidal CO2 of 50?
Correct.
It seems like you guys should probably continue ACLS efforts and consider transport to the hospital. Just kidding.
Yeah.
He's got a lot of positive factors going in his way. It was witnessed. He got bystander CPR. It's been less than 30 minutes, and you've had an improvement in his rhythm from ACLS or from asystole to PEA organized at 100, and he's got end-tidal that's good at 50.
All right, we will transport. Do you want to give Rose a heads up? Probably 10 minutes.
I will give Rose a heads up. Thanks.
So you can see there, as I was hearing all that, and I could see your face, Jason, as you were taking all that information in as well. Your head kind of starts to turn, and you're like, there's a lot of positive predictors of this patient could have a good outcome. And so now my job is to somehow get the paramedic onto that mental model with me to maybe take this call in a different direction.
And that patient may have had ROSC and is just profoundly hypotensive.
Yeah,
right?
at that point, right? They might just be non-palpable, and you throw a probe on and you see pulsatile movement. I like it.
And
I like
so-
the mental model idea. Sorry, go ahead, Will.
No, even disrupting that paramedics, and when I say disrupt is maybe a word that we conjure up confrontation, but I mean like that paramedic has been in this mindset of like, we're working this asystolic arrest that seems like it's going to have a poor outcome, and breaking their cognitive bias a little bit of like, hey, you may have actually achieved ROSC. You know, you would hope that a mindful, truth-seeking medic would be like, oh my gosh, you're right. Yes, thank you. Like, I need to switch gears.
Mm-hmm. I like that. And Ross, I don't know if there was a shift change or if you're able to do so, but without getting too much details of that case, do you know, would you offer, or did you do in that situation, the sort of away from others debrief with that person? Did you talk about the options? I mean, you did such a concise and good job of explaining your mental model on the radio that it might not have been necessary, but how would you recommend rounding out that communication with that medic after the fact?
Yeah, definitely. I think if you have the opportunity, you should take every opportunity to do that because it's going to strengthen your relationship with that medic. It's going to strengthen their trust in you when you're giving them advice over the phone. So yes, this is a big, busy system, and I didn't see them for the rest of the day, but I did have the opportunity to go to the division afterwards, discuss the call with the supervisors as well as that paramedic, and just have a debrief afterwards to be like, hey, do you understand where I was coming from? Like we only had a limited time on that phone call, but I just want to make sure like we're clear. you understand where I was coming from. I'm not trying to make your life harder. And so, yeah, and they were very understanding of that. I, to your point, actually had a recent call that I gave you one where I looked very good. I had a recent one where I did not do so well. And this was fairly recent, and I reflected on it, and I actually pulled the paramedic aside. So he called me with a kiddo who had was having seizures, and he had given benzos. It was like a 5-year-old, no history of seizures, has given benzos, was still seizing in front of me, and asked me what to do. And I said, "What are your vitals?" He said, "I don't have any right now." And I said, "Do they have a pulse?" And he's like, "Yes." And then I was like, "Okay, I'll wait for a blood pressure." And reflecting on that case, this going back to like, what do they need in that moment? And what do they need and what do I need to know? They don't need me to harp on the importance of vital signs. Like, what I need to know in that moment to help them out is to understand that they have a 5-year-old in front of them. And turns out they have a 5-year-old at home. That this is a high anxiety provoking call for them. They have given the normal algorithmic type response, and it's not responding like they would expect it to. And so they've hit the end of their algorithm, and they now need help navigating that further. And what do I need to understand? What do I need to know to help them navigate that? What I need to know is that they're managing their airway and that they have a pulse. And if they manage their airway and they have a pulse, we can move forward, and I can talk them through, like, yes, is having a blood pressure important? Yes. Do I need it in that moment to help them move forward? I do not. And so what I wish I would have done in that moment is assured that they were managing the airway, assured there was a pulse, and then told them to give more benzodiazepines because they don't have access to other medications. And then I would have said, please work on a blood pressure and access on your way. We'll see you when you get here. We'll be ready. And so that did not go well. I did not do well on that call. And after the fact, because they brought him to my emergency department, I was able to pull that paramedic aside afterwards and apologize and say, "Hey, I was poor on that phone call. That is not what you needed from me. And here's what I wish I would have done instead." And we talked about, we did some education surrounding the call and what was going on. And he shared that he has a little one at home. So that was producing a lot of anxiety as well. And so you're absolutely right. That ability to debrief after something like that can go a long way for these.
There's one more scenario that we don't have an example of that I do teach paramedics about that I think is valuable to discuss with physicians, and that's utilizing you guys as a tool. Now we're kind of doing that all of the time, but I wish we had the recording. But one of the very few times when Ross was in his physician training and I was still in the field that we talked to each other on the phone was basically a high risk refusal out at the Denver International Airport. And so this gentleman had experienced chest pain on his flight. They had asked for paramedics to meet them at the gate. He had he was not having a STEMI, but he had some, I think T-wave inversion, something, on his EKG that we have one EKG. We have no way to normal for him. He is adamant, I don't want to go to the hospital. Denver was a stop along the way. He was trying to catch a connection flight, and his family was even worried about him. And he was like, "No, we're going to wherever, Cancun or whatever they're going to." We went so far as to tell him, "Sir, you could be having a heart attack, or this could be the start of your heart attack, and you could get on your next flight and you could die." We went up to saying he could die, and he said no. And we have one tool left in the toolbox at that point, and that is to call the doctor. And, paramedics need to realize this. Yeah, it happens in my own family. When someone hears it from a doctor, it just carries more weight. And so we call base. Ross answered the phone. We did our job explaining everything we had done. This man has decision-making capacity. We've explained the risks up to telling him he could die. Would you please talk to him and communicate your level of concern for him? Absolutely. Put Ross on speakerphone. The family's listening. The patient's listening. The medics are listening. Ross goes through basically. Ross didn't do anything except repeat the things we had already told him. And after that, the patient was like, "Yeah, I guess I'll go."
Yeah. Yeah. And who knows if that was, again, the hi, I'm the doctor. I'm here to reiterate that, as you said, Will, but I wouldn't give yourself any discredit there. And maybe it needs a second time around to sink in and seeing that people are truly concerned. Maybe it was a look from the significant other who's like, don't mess around with this. Who knows what turns the tide for that individual, but I hear what you're saying. And, in that same self-reflection, I think my areas where, like Ross, I've been less than a communicator that I would not want to have a recording played back to me of, is in those times where I'm not sure what the direction is going. And when it is like, I am looking for X, Y, or Z, I just wanted to bring it back to that thought, because as EM providers, I think of that's a kindred to when we're calling cards, right? Hey, I have a patient I think is going to need stress test tomorrow. Here's a story. I have X, Y, or Z who I think is going to need grafting, hello vascular X, Y, or Z. And so having that structure, having that shared mental model, if you're finding that that's not the case in your communication with your EMS personnel, what's your relationship with your EMS director, and what are you doing? What are they doing? What is your system doing to try to develop that same modeling? And so I recognize and appreciate, and I think it's actually easier for us to understand as EM providers when we hear this experience, because it's so shared, right? The specialty service with whom we're communicating doesn't know our environment, doesn't know what we're dealing with, and we have to convince them of X, Y, or Z that we want from them, basically, right? And so if we can help teach or structuralize or understand that and educate our EMS personnel, but like, that's fantastic that you did this. Can you lead for me with the I'm looking for a refusal? Because I listened to that 3 minutes of confusing family story, and now I understand as to why you're calling me. So helpful for me. I also am curious your guys' perspective or opinion, if I could get a little bit more specific in the space of doing or not doing things, right? And coming back to that idea of mental modeling. So, the post-ROSC COPD patient intubated, getting call for that, and they're saying, decreased breath sounds on their left, we're going to move forward with needle decompression. Asking or thinking about, okay, one of my areas of question or concerns is, during this, often we're right main stem. Do you guys feel comfortable with pulling back without risk of extubation and reassessing breath sounds before proceeding to that? That idea makes a lot more sense to me now that I've had this conversation with you two fine fellows, rather than, don't start needle decompressing this post-ROX person. Like, you're probably just right main stem. So thoughts about that, or how one can communicate such things to the pre-hospital space, and what diving more specifically in that area of like why we might want you to do less, if that makes sense.
I mean, the way you approach it, I think you phrased it perfectly, was in the form of a question that expresses, like, do you feel comfortable with this, their comfort level, and expresses your concerns and your mental model. And so I think if you're going to do it, that is the perfect way to do it. And like Will said, using the clinician as a tool, as a resource is something that can be very beneficial to you as the EMS clinician in the back of the ambulance and to the patient in front of you. And so not being afraid to use that, I think, is really important as a paramedic, if you're being asked to do something maybe less aggressive than you want to.
Yeah, I think about back to something we talked about earlier, just being respectful and wanting to be treated like, a colleague in a sense. And so if that physician on the phone says, as I'm not there, but as I'm listening to this, if it were my patient in front of me, I would be concerned about right main stem. I'm just curious about your tube depth before we go ahead and needle decompress this patient.
I like it. Thank you. All right, just a little more confirmation of these ideas and processes. And the model is what matters, right? Because we're never going to role play all of the potential craziness of your lives, our lives. And so thinking, is this within your ability and scope? Here's my mental model. Here's my question. Even that simple of a structure is super, super helpful. So, all right, I've had you guys' ear and your thoughts and opinions for a while now. If it's all right, I'm going to try to wrap it up do a little summary and have you guys supplement that. Does that sound all right?
Sounds great.
All right. So we have Ross and Will here who are experts in the space of EMS preparedness, with Will being a medic and Ross being EMS control as well, director, and the creators of the Loud and Clear podcast, working with EMS personnel in that space, as well as in your other areas. And we'll have links to the amazing work you do in creating communities of shared experience and progress to avoid some of that skill decay and make sure that people feel ready for not just their initial couple years as a medic, which is certainly a focus, that shaky ground and green behind the ears, but also losing that fear of skill decay, knowing that you have a community of providers like you guys have created to keep your skills up. And so with your expertise, we dove into kind of the areas of preparedness, communication, and expectations. First asking you guys about what's it like as a medic? What are the expectations in preparedness to keep up a certain number of reps, for recertification, for credentialing within your organization? And unsurprisingly, it's regional specific and it's variable, just like we as EM providers have, right? It's going to depend on your institution. It's going to depend on your environment. And a lot of it in the end sounds like it's going to depend on you and your colleagues. Are you guys and gals willing and able to keep your skills up so that you're ready for whatever comes through the door? Because accrediting bodies aren't going to be the ones holding the ownership there. Then we kind of went into communication and asked, my first area was, is there a structure that all paramedics are taught in paramedic school? And Will said, no, basically. Like, there's a structure that we can talk about, like the leading with the punchline, talking through a specific the important points, but a lot of the education there comes in your field work and the area that you're practicing, developing skills specific to either the agency or the region with whom you're going to be growing as a paramedic. And then finally, we talked a bit about expectations kind of on both sides of the spectrum, whether it be, can I ask them to do something that that's more aggressive than was the initial report or request over the phone or radio? And then what about doing less, about asking them to do less, spend less field time, maybe not intubate, maybe not needle decompress in the example we had. And I really like the idea of the mental model, understanding where they're coming from, explaining your thoughts and mental modeling, and then adding with that as a question, understanding you're not there. So you're giving the final determination to that medic with whom you're asking or working. How'd that go? How's my summary, guys?
That was perfect.
Yeah, great.
Anything to add or augment, or otherwise we'll make sure that we have all of our audio files and references in the show notes. But I appreciate you guys coming on. It was a blast to have you guys here, really pick your brains and think about how I communicate. I have a lot of opportunities for improvement in, thinking about the cases that I've gone through. And I know I learned a lot. I'm sure our listeners did. So thank you guys for joining me.
Yeah, thank you
so much for having us.